Health and Social Care Integration Joint Board. So this is the second meeting of the IJB that we've held remotely, and I can confirm it's the first one that's been recorded. So it's an important step for the IJB. As you know, normally we hold meetings in public and the public are welcome to attend. So we thought it was really important that in terms of scrutiny that we do make this meeting public. So I can advise all the members that the recording of the meeting will be available to watch both on the Council and the HSCP website following the meeting. I know most of you are now familiar with Teams, and Elaine Curry, thank you for providing us with some guidance. But if I could just go through a couple of points just as a way of reminder. It's important when the meetings are being recorded that it's only the person speaking who has the microphone on, particularly when it's being recorded. If there's any background noise, the camera will jump to the person that's speaking or the noise. So just so that only the person that's speaking is on camera, can we make sure that we have our microphones muted? Also, I know it doesn't feel very natural, but if we can try and have a short pause between speakers so that the recording can catch up and go on to the person that's speaking. So if we try just to have a second or two gap between speakers. And just to let you know that we've got the chat bar at the side, and the conversation bit is also open to the public. So be aware of that when you type any comments, that they will be there for scrutiny as well. So also, I don't know if we've got any members accessing by phone, but if you are, could you also put your phone on mute when you're not addressing the meeting? So before moving on to the agenda, I'm going to ask Elaine to do a roll call of members so that it's clear for the recording everyone who's here. So Elaine, I'll pass to you.
Okay, thank you. We have obviously yourself, Councillor Jacqueline Cameron. We have Councillor Lisa Marie Hughes and Councillor Bill Binks. We have Margaret Kerr, John Matthews. I then have Karen Jarvis, Fiona Milne, Stuart Sutton, David Lees, Sarah Lavers. There's myself, Elaine Curry. We have Ken Graham the Clerk. We have David Head, our ICT technician. We have Shiona Strachan, Francis Burns, Karen O'Byrne, Jackie Dougal, Jean Still, James Higgins, and is it John Miller? Is there anyone that I have missed?
Elaine, Christine.
Oh, Christine. See you now, thank you.
Dorothy Mackerlane.
Oh, I'm Dorothy.
David Wiley.
John Boylan.
Louise Mackenzie.
And Mark Ferris from Audit Scotland is also here.
Okay. Thanks for that, Elaine. I didn't do my 2-second pause there. Yeah, I think I don't think I've got this in my instructions, but in the instructions that Elaine gave you, just to go over the fact that if you could raise your hand or type a Q in the chat bar if you want to speak. I've got the chat bar up and I can see hands up. Now, John Boylan, you've got your hand up at the moment, but I'm suspecting that might just be to say that you were here, but yep, the hand's gone down, so yep. I'm assuming you don't want to speak. Right, thank you, John. Okay, before we move on to the actual agenda, you'll notice that item 3, page 17 to 18, we've got an IJB membership update. But before we come to approve that, I wanted to ask our new members, subject to approval, to introduce themselves. So I'm going to introduce Reverend John Matthews and Mr. Francis Shannon. So if I could ask both of you to say a few words, and we'll start with Reverend John Matthews, who, subject to approval, will be the Vice Chair of the IJB.
Okay, I have your permission to speak.
Yes.
Can I just deal with the Reverend first? I'm John Matthews. I don't have that moniker at the front of my name, not because I'm denying it, I'm in denial or anything. There's still a wee bit of me you'll find as a clergyman. And I was 20 years as parish minister in Ruckhill, Postle Park. and it was at a time half a dozen years ago when it was in free fall, and really astonishing conditions in which people lived and moved and had their being. Before that, I was a wee boy in Garngad. I'm a Glaswegian, born and lived for the first 23 years of my life a mile away from George Square, which is where Garngad is. And my wife always said that she married me and recovered me out of poverty, because she came from East Kilbride and was very posh, and that's probably true. I then went on to clamber my way up the greasy pole to be the chief executive of the tungsten carbide businesses for American General Electric, which is where I served most of my career before I then came back to Glasgow with my family to study at the University of Glasgow for the Ministry of the Church of Scotland. And since then, I've tried to be helpful in being on the board and deputy chair of Scottish Enterprise Glasgow, the Glasgow Alliance, all those usual things that you end up being on when you're in a public body of that sort. And 4 years ago, I joined the board of Greater Glasgow and Clyde, and now it's vice chair. I think that's enough. In fact, it's too much.
Thanks very much for that, John, and thanks for clarifying that we can call you John. As I think I said to you earlier, on this board, we dropped the councillor as well, so it's Jacqueline from me. Elaine, I've just noticed an email come in from Frank that he can't get on. Is David Head helping him with that at the moment?
I've just messaged David Head, so he's having a look at it just now. So we'll let you know when we can get him into the meeting.
Okay. Right. I think probably the best thing to do is just carry on with the meeting for now, and hopefully by the time we get to the membership update, Frank will be able to join us. And at some point during the meeting, we'll introduce you to Frank anyway. Yeah. So Eloise Francis, Frank's also Frank, so that saves some confusion from Francis Burns. Can't say the same for the Davids, but anyway. Okay, I've noticed that John Boylan, you've got your hand up. Are you wanting to speak, John? No. And Bill, you did as well, but I think that was just maybe a mistake. No, you don't want to speak, that's fine, good. Okay, right, now we can move on to the agenda proper. Are there any apologies, Elaine?
I have apologies from Councillor James McLaren, and his substitute, Councillor Bill Binks, is in the meeting. And apologies from Alan McNiven and Stephen Cruikshank.
Okay, thank you. And are there any declarations of interest from any of the members? If there are, if you just put your hand up and I'll come to you. Nope, no hands, so no declarations of interest. Okay, so we'll move on to item 1, which is the minute of the last meeting. If anyone has any questions or additions or amendments for the minute, can you raise your hand? Nope, no hands raised, so we're all happy to approve the minute, and that's the minute approved. Okay, moving on to item 2, which is the rolling action log. Does anyone have any questions about any of the items in the rolling action log? Nope. Yep, sorry. Yes, Mags, if I could pass to you.
Thanks, Jacqueline. It was just to clarify, some don't have a status against them. I think we've talked about this before, but I do find it a little bit confusing with the rolling action log as to what the expected close date on some of there are. You know, the second item's got a due date of 26th of June, but no status, for example, and there's a couple of examples, so it'd be just good if we could clarify those, not necessarily in the meeting, but if we look at that going forward, please.
Okay, thanks for that, Mags. Yeah, we can have a look at that. The one thing that I wanted to say was that last IGB we looked at the social isolation and loneliness champion, and Jennifer Adam McGregor had agreed that I could take on that role. So it was just to let John Matthews and Frank Shannon know that was happening. And I think in the minute we recorded it, but I wasn't sure whether it was approved. So I just wanted to make sure that everyone was happy with that and that we can approve that officially. So if there's any objections to that, raise your hand. And Mags, your hand's up just now, so I'm presuming that's from last time. So if anyone's got any objections to me being the social isolation and loneliness champion, speak now. Okay, there you go. That's me. I've got my new role. Thank you for that. Okay, so we're moving on now to item 3, which is the IGB membership update. Elaine, do we know if Frank is here yet?
I don't have him in the meeting as yet.
Oh,
I'll
right.
check with David and I'll get back to you.
Ken, can I just clarify, can we approve this paper without Frank actually being here?
Yes, you can.
You can't, right. Okay. Okay, well, I'll go ahead with the paper, and hopefully we can get to speak to him at some point in the meeting. Okay, so who am I passing to? Ken or for this paper?
It's for me, Jacqueline. It's Jean.
Jean, okay, Jean.
Okay.
Okay.
Thank you. This is the formal report providing an update on the voting membership of the IGB. It confirms that John Matthews has been appointed and will assume the position of Vice Chair, and also confirms that Francis Shannon has been appointed to the IGB, replacing Donny Lyons and Dr. Linda de Casticker respectively. So the recommendation is for the IGB to note the membership changes as recommended by NHS Greater Glasgow and Clyde. Thank you.
Thanks, Jean. I just wanted to say briefly as well that unfortunately we didn't get a chance to say formally a goodbye to Dr. Linda de Casticker. I did email Linda and just thanked her for all her contributions to the IGB as well as the Alcohol and Drug Commission. She's replied and said that she'll still be involved in some way or another, and we're not going to say goodbye forever. So I just wanted to formally thank her for her contribution and all her expertise over the years, particularly obviously in the area of public health, and she remains a Director of Public Health and will be involved with us. Also, I think we've already covered Donny's farewell in great detail, and Elaine covered that in the minutes, so that's recorded as well. So, but we'll thank him again. So hopefully we'll get to speak to Frank. We've welcomed John as Vice Chair, and I've had a chance to catch up with him and Frank, and we'll all get to know each other going forward. But unfortunately we can't introduce you to Frank at the moment, but we'll do that at some point later on in the meeting. Okay, so the recommendation is that we note the membership changes as recommended by NHS GGC. So if everyone's happy with that, I think I've got somebody. Has someone got their hand up? No, there's no hands raised. That's fine. So we're happy to note that item. Thank you. Okay. Sorry, I'm just going to have to flip back to my agenda. Okay, right. Yep. So our next item is item 4, and it's an operational services update. Now, we didn't have this in advance because it's just a brief presentation with some bullet points. I'm asking the service leads to keep this fairly brief because I want to open it up to questions at the end. I think that we've had a lot of information during the COVID crisis. We've had briefings, we've had our development sessions, and we've also had the opportunity to speak to service leads or email directly. So I'd like to thank everyone for keeping us so abreast of what's going on. But in each IGB and development session, we've had verbal updates just because things have been changing and the pace of change has been so fast. So I'm going to pass to David. And we'll go through the presentation and we'll leave questions to the very end because each service lead is going to give their update. So David, I'll pass to you now.
Thanks, Jacqueline, and thank you for the context. Yes, as you said, this is an update by Head of Service, as well as an update from David Wiley as Head of Podiatry, recognising that we host on behalf of the whole GG&C system, the podiatry service, both acute and community, and also an update from Stuart Sutton around the primary care elements. I've asked each Head of Service to keep it relatively brief, given, as you've said, the information that's been shared already, and that will then allow the opportunity for questions. And also because I think that the presentation update that will come under item 6 with that short paper will provide the context in terms of moving on to next steps. So at that point, I'm going to pass on to James first of all, just to bring the slides up onto the screen, if that's okay. It might just take a little while just to get that upload. Okay, and if you could just move on to the first slide, James, if that's okay. And I'm just going to pass on to Siona Strachan at this point, and Siona's just going to give a quick update on these items, and then we'll follow on with heads of service in sequence thereafter. Thank you.
Okay, good morning. The areas of service are laid out in the first 2 slides that I'm going to talk to, and I'll hand over to Karen for the last 3 service areas. There are some key themes across the services. Services have been operating, as you know, to core services or critical levels of need. Day support is the only service which has been stopped, and respite continues on an emergency-only basis. Shielding and self-isolating staff have had an impact on capacity to respond, although we are carrying out work to support them to return to work. Visits and other tasks take longer due to infection control measures and will continue to affect our capacity to respond. Deployed staff are now being phased back to their original teams to support the switch up of services to include substantial levels of need and, crucially, rehabilitation and re-ablement functions from August. Community-based services continue to cohort staff, with staff working from home and some movement on office bases being re-established, such as Abbey House and Johnson Town Hall. Teams continue to use IT and attend anywhere technology to support assessment, and also are now continuing to carry out essential visits. In terms of specific services, the DN and RES services, in addition to now moving to carry out rehabilitation functions, have provided substantial support to the care home sector across the period of pandemic and will continue to do so. They are now also preparing to support the flu programme as it rolls out. In terms of hospital, our delays in discharge continue to be low, but we do continue to wait the courts moving to full operation to allow the adults with incapacity cases to move through. Care homes are relatively stable at present. We do have a full report on section 5 of the agenda, but you should note that there's considerable media and political interest in this area of service. In terms of day support staff, they remain deployed, particularly within the care homes, and we are currently working on a hub and spoke offering to support people at home rather than a traditional building-based service. Contracts for day support are being reviewed with our providers, and these contracts are due to come to a natural end anyway over the coming few months. Care at home, we are beginning to pick up the redesign work as part of the Older People's Review, which the IGB agreed pre-COVID. We have an ongoing recruitment of staff during the period of the pandemic, which has actually been successful, and that is supporting our ability to deliver services to people with lower levels of need. I'm now going to hand over to Karen.
Thank you for that, Siona. I'm going to touch on 3 different areas: adults with incapacity, adult support protection and staffing. To begin with, adults with incapacity, everybody will be aware on the 23rd of March, when lockdown commenced, the Scottish court system effectively shut down to normal business and all matters in process were effectively halted. This impacted significantly on a large number of both private and Chief Social Work Officer AWI applications that were caught in process. And whilst we continue to robustly manage these and progress adult with incapacity delays, these were related to in particular related to delayed discharge. However, many of these delays, as you'll be aware, were out with our control despite regular chasing of solicitors. What was an already complex and challenging area of work became even more so with the impact of COVID. So with regards to the current picture with AWIs, courts are not likely to have any face-to-face hearings for some time still to come. So any contested cases requiring evidence to be heard will continue to be some time off. And I suppose to put that into some kind of statistical context, in April to July 2020, our data showed an average of 8.7 to 9 delayed discharge for guardianships, and for the same period the year previously we were showing 1 to 1.2 delays. So that gives you an indication of some of the impact of the court process and the delays surrounding that. With regards to our adult support and protection, to compare our stats to June 2019, in June 2020 we have seen quite a significant increase in overall adult protection, 14% in fact, and this is in contrast to April and May 2020, which saw quite a significant reduction in our stats. In 2019 and June 20, we saw an increase in referrals relating to people under 40, which is quite significant because our other areas, our stats remained consistent. So for that over 40 age group in June 20, we have seen an average of 34% increase. The referrals for adults aged 18 to 29 rose significantly as well, with a 32% increase. The number of referrals for age 30 to 39 rose by 23%. So what we're seeing is a proportion of referrals increasing, but the age range in which we're receiving referrals is actually lowering. And again, that Christine will go on to talk about some of the reasons for that, but a lot of that is related to anxiety, and it's people who we haven't normally seen through our service. If I go on now to staffing, there has been a piece of work has been undertaken recently in relation to staffing, and we've been looking at those staff who throughout COVID have been stepped back from the service, and that
Karen, your mic is muted.
Yep.
Apologies. Is that better?
Yep.
Okay. Sorry, was it muted throughout the whole staffing input or?
No, I think we just missed the last few seconds of what you were saying. I think maybe if you start from the staff bit. Yeah.
Okay, thank you. For the past few weeks, there's a piece of work has been undertaken to start to return those staff who've been stepped back from their service, either as a result of being in a high risk category and unable to undertake their normal pieces of work, or for those staff who have been in the shielding category. For the staff in the high risk category, we've worked alongside health and safety, HR and occupational health, so that we are in a position to safely return staff to either their normal work or to undertake other pieces of work that maintain their safety. For our staff in our shielding category, what we've started to do is start to have conversations with them about how they're feeling in general, but also looking at how we involve our occupational health, our health and safety. And for those members of staff in particular, we're aware of some of the impact that COVID and that need to shield has had on their emotional well-being. So we're utilising all of the supports in terms of time to talk or counselling, etc., to ensure that staff are feeling safe and are feeling confident in terms of trying to get them to return into the service. Okay, that's myself. If I hand over to Christine, who'll start to cover areas around learning disability.
Okay, thanks, Karen. So learning disability, as you know,
Sorry to interrupt. I just wanted to check, there's in the chat, a few people have been saying that they can't see the slides, and I know James has restarted them. If people could just maybe type and let me know whether they can see them or not, but just to make everybody aware that it is bullet points and headlines, and if we can't get them, the issue resolved, we can send them to people. But really, I think what's important is what's been said rather than the actual bullet points. Sarah can't see. Other people can. I think we'll just carry on, and apologies to the people that can't see them, but as I say, it's bullet points and headlines, and I don't think there'll be any information that you'll be missing. So I'll hand back to you, Christine. Sorry for the interruption.
Thanks, Jacqueline. Okay, learning disability services, people will be aware that our day services had to close right at the beginning of lockdown. We quickly developed a 4-tier model of support and have continued that throughout the pandemic. So that's care at home, welfare calls, doorstep visiting to deliver shopping and medication, moving through to daily exercise, day respite, and also crisis overnight respite at our Weavers Lynn respite centre. Also a whole range of things and activities available on social media. Our community services continue to work and provide a multidisciplinary support and treatment to people with learning disabilities, and we've also now got our learning disability planning group, which includes carers and families, back up running virtually. James, if you just go on to the next slide. The emerging issues for our learning disability services are just as time goes on, the increasing impact the day service closures has on families. Also, families who've been unofficially shielding have a real high level of concern that they've shared with us about what risks are around for their loved ones when our services open again. Families are also expressing concern about the very small number of people with a learning disability in Renfrewshire who've been officially recognised as vulnerable in the shielding list. Out of 650 people open to us, only 10 are officially shielding, which has been an issue that's been raised with us. Okay, I'm just going to move on to mental health, I think is the next slide, James. So Inpatients, as you can imagine, has continued throughout the pandemic. What has been different within our wards is we have cohorted into wards in relation to COVID. So we've had red, amber, green, and that's to allow us to allocate staff teams to reduce the footfall on our wards and make it safer for our patients. When visiting stopped, we moved very quickly to adopting video conferencing. So we use iPads to allow families to remain in contact with their loved ones as they are an inpatient. Very recently, mandatory staff testing has now been introduced in all our older people and our continuing care wards, as well as learning disability. We've reintroduced our visiting and time out of the ward, and also we're looking at proposing a 12-hour shift pilot in our wards because we're losing quite a number of staff who prefer 12-hour shifts, and they're making sideways moves into other areas. Okay, so the emerging issues for mental health in inpatients are the cohorting of patients have been difficult for us in Renfrewshire because we're based across 3 sites. We also, all of our wards don't have single room and ensuite facilities. Similar to every hospital across Greater Glasgow and Clyde, any patients with a cognitive impairment, physical distancing, wearing a mask and regular hand washing is a challenge, and that's particularly challenging in our older people wards where many of our patients have dementia. Okay, moving on to our community services. Service delivery, it's a critical service, so we've remained delivering our community mental health service. We have paused our Doing Well service, which is for mild to moderate mental health issues, focusing on our intensive home treatment team and also focusing on our community mental health team. So we've continued to work. The biggest change for community mental health has been we, in a bid to divert mental health assessments and people away from RAH Emergency Department. We joined forces with colleagues across GG&C to be part of the 2 mental health assessment units. Ours is in Levendale. The CMHT have completely focused on delivering essential services throughout, and where appropriate and where required, we have been seeing people face to face. The other services have been working at a reduced level, but we have been seeing people and being prioritising those in greatest need. Okay, moving on to the emerging issues for mental health. One of the challenges which Siona talked about is that we've redeployed staff into some critical areas, particularly our crisis team and particularly the mental health assessment unit. And that's a challenge for us to open up some of our services that we've paused. Accommodation is a challenge in some of the older buildings that we are based in are not particularly suitable or lend themselves well for physical distancing. And there has been a lower uptake for some of the solutions on digital platforms, particularly for our older adults. So we are looking at how we build capacity within our mental health community services, because we know that the demand is increasing, and particularly in relation to the impact that COVID has had on people. Okay, moving on, James. So alcohol and drug recovery service is a critical service, and that has continued throughout the pandemic. We have reduced some of the support we give, particularly to shared care, to our colleagues in general practices. And we have, alongside all other areas within Greater Glasgow, we have eased the supervision and dispensing of methadone, but we've also increased the provision of naloxone to keep people safe. Again, using all the telephone and video conferencing. Unfortunately, we had a fire in the Torley unit on the 1st of June, so that has given us compromised our contingency plan in terms of how we see people face to face. We're delivering medication where appropriate, and there's a whole range of digital support, particularly around recovery, which people in Renfrewshire have made good use of. The Recovery Hub building work has recommenced, and our recovery manager recruitment is underway at the moment. The emerging issues for alcohol and drug recovery service is the accommodation challenge with the Torley unit fire and Back Snedden Street. Because of the physical distancing required, capacity has been reduced to 2/3. So that is a challenge that we're working through at the moment. Okay, who I'm passing to? I'm passing over to Jackie.
Good morning. A quick overview of children's health services. Our health visiting service, initially following the Scottish Government and guidance, was to focus on young babies up to the age of 8 months, our vulnerable children, and supporting families to take up routine childhood immunisations. However, since the beginning of June, all child health assessments have been reintroduced, and their services working their way through catching up on those that missed during that short period. Our CAM service continued to provide an essential service prioritising those in greatest need, including offering emergency mental health service assessments to those children that required them. Our wider children's health services continue to provide a critical level of service required to support children for hospital discharges, preventing hospital admissions, replacing broken equipment or support to care placements. They provided services to families through a centralised hub model based out with Renfrewshire Centre in Renfrew. All the contacts in children's services either took place face-to-face, via telephone or using Attend Anywhere, and work is underway to build capacity across the services through the recovery journey. During COVID, we had to develop 3 new services. James, next slide. Sorry. 3 new services were established. The first being our Renfrewshire Assessment Centre, which was responding to people who were experiencing respiratory symptoms. related to COVID, and that continues to be delivered out from Linwood Health Centre. Nursing staff have been redeployed from the HSCP into the centre, including offering placement to final year nursing students, supported by admins and GPs. Attendance numbers continue to reduce, which is positive, and these continues to be closely monitored. PPE, with regard to PPE, the HSCP established a centralised distribution centre model supported by our council colleagues, which received both a health and social care delivery on a weekly basis from our national distribution centre. The hub distributes PPE across all HSCP services and acts as a central pick-up point for care providers, care homes, home care providers, and to make sure all services have adequate PPE, which is crucial around service delivery. We receive regular adequate supply of PPE, and we currently have no concerns regarding availability of PPE, and we continue to monitor the demand to ensure an adequate supply flow, especially as services reopen. Care home testing team again was co-located into Linwood Health Centre, and it continues to offer testing to symptomatic care home and nursing home residents, surveillance testing a small number of residents in 2 care homes each week, and supporting the care homes with staff testing. The tests are undertaken by redeployed staff, both from nursing and podiatry from across the HSCP, and the feedback from the care homes has been very supportive and positive. I'll pass you over to David Wiley. Oh, sorry, Stuart Sutton.
Sorry, I wasn't prepared there either, Jackie. I thought it was David too. I'll just run through briefly some of the updates around primary care. I'm not going to read the entire slide because it's quite detailed. In terms of the primary care improvement plan, which is, as you may know, the implementation of the new GP contract around the expert medical generalist role for GPs in the future, and providing an additional multi-professional team around primary care that would support people accessing general practice to see the right person at the right time. That work is ongoing. It's fair to say that that's been challenging in the sort of 3 or 4 months through lockdown and during COVID, and certainly implementing entirely new systems and processes and staff groups has been challenging. However, we're well on track to recovering the progress we were making prior to March. The first 2 new treatment rooms, which will be community treatment and care rooms, will be for nursing type services, including removal of sutures, dressings, ear care, etc. Are planning to be opened in Renfrewshire Health and Social Work Centre, as well as our first virtual pharmacy hub, which is a way of trying to maximise the impact of our practice support pharmacists in undertaking medication reviews, level 1 pharmacotherapy services such as acute prescriptions and discharge letter medication reconciliation. I won't go into the COVID assessment centre because Jackie's covered that. It does remain open. Work is ongoing in terms of the planning for this over winter and into spring. It's fair to say the expectation is the demand for people presenting with febrile and respiratory illnesses that may be COVID or maybe something else that isn't COVID but presents in a similar way is likely to increase over the autumn and winter period, and planning is underway board wide with regards to that. In terms of general kind of primary care updates, ongoing large numbers of virtual consultations. You'll see I'm sat in the surgery at the moment and have been doing virtual consultations this morning. Chronic disease management is gradually returning, so phlebotomists are back in practice, focusing on the most high risk conditions or people who have uncontrolled chronic diseases in particular, because due to PPE changes and social distancing, the volume of that work isn't possible to be able to continue at the same rate. Ongoing work around GP care home palliative care relationships and meetings continue to be held on a fortnightly basis. Buddying practice arrangements, and that's in case a practice ends up with an outbreak or multiple staff off sick, that's in place to provide cover should one practice, in extremis be unable to open or be unable to provide care. In terms of, sorry, I've got a barrier in front of my screen there. In terms of demand, I think that did fall short term in the first few weeks of lockdown. It's fair to say that understandably people have held off as long as they can with not only urgent conditions but less urgent conditions, and they are needing support and to be seen. GPs are open, they are triaging patients remotely, and as I have this morning, they are seeing people face to face where appropriate. What we are still not doing is having a process where people can book a face-to-face appointment without having first spoken to a GP, and that's primarily around safety, both for patients and for staff, and just to ensure that people who need to be assessed face-to-face with PPE are offered that opportunity. If we go on to the next slide, please, James. Again, I'm not going to go into detail about flu. We'll probably have more of an update at subsequent IGBs, but suffice to say the flu programme this year is going to be challenging. Again, social distancing, PPE use will mean that the traditional method of very large-scale flu immunisation clinics in general practice are not feasible this year. The cohort to be identified for flu vaccination is likely to be significantly increased. We're waiting on confirmation from the Scottish Government, but you'll have seen that in England that cohort's been included. A 50 to 64 cohort has been included that was not included previously. So work is underway to look at mass vaccination options board-wide and locally in terms of how the HSEP will support the delivery of flu vaccinations, both for at-risk groups, age-related groups, children, as well as staff peer immunisation. Briefly mentioned the new Pharmacy First service. That's an extension of the minor ailments scheme. And that's now open to anyone living in Scotland without the previous restrictions that were there around people who would have been eligible for free prescriptions under the old regime, and that's launched as of late July, so currently. And that's me. So I'll hand on. I think is David next? Yeah. Okay.
Thank you, Stuart. During COVID, podiatry operated at 31% of its normal capacity from 17 bases. We limited our service provision to those conditions that were likely to potentially cause admission to hospital. People with foot wounds, people with infected ingrowing toenails, people with infections and at high risk of ulceration continued to be seen. During phase 1 of recovery, we have continued to work from the 17 bases that we currently were providing services from during COVID. The plan has been to invite patients who may not have had foot wounds but were regularly requiring treatment for painful keratinized lesions, painful corns, painful conditions in their feet that limited their mobility, and they saw us every 4 weeks or 5 weeks or so. And that recovery section or phase has begun. We've also started to see people with MSK and orthopaedic foot and ankle problems. We're seeing a lot of them virtually, as with everyone else. I won't repeat all of that. But those who do require treatment are being seen centrally at our facility in the Queen Elizabeth University Hospital, which is a large standalone facility where we can socially isolate or socially distance and still see quite a high volume of patients. The plan for us as we move forward, having done what everyone else has done and split our demand into a number of phases, is to increase the capacity to 71%, possibly towards the end of October time. And then we'll bring on patients who need to see us every 5 to 8 weeks. And then beyond that, you'll see the capacity increasing through to phase 3, etc., when we start doing some elective work again. Of course, should there be any further spike or further challenge, because we've been able to understand our service really well, we can just roll these phases back if we need to at any point in time. We do face some accommodation challenges. One man's meat's another man's poison. In that sense, Christine is using some of our facilities in the Snedden facility to accommodate them from the Torley, and we've had to move out of there. So we work together in that respect. James, can I have the next slide? We do have some problems in East Dun and in Renfrewshire around accommodation, but we are working with local administrators to resolve these as the demand increases. In terms of, so all of that was for people who were currently existing patients. For new patients, during COVID, we weren't receiving any new referrals apart from the categories that I mentioned earlier. Now we are receiving referrals as normal pretty much, but the patient experience isn't the same. As with most other services, we're now telephoning, the patient is being appointed into a telephone appointment. It's not just a kind of ad hoc telephone call. You will get a telephone appointment, and from that telephone appointment, you will either be given a near me appointment if we think we can make a decision just by seeing the problem, or a face-to-face. We're also mindful of people who may not be able to use technology, and if they're not able to use technology, they'll be given a face-to-face appointment. To give you an idea of where we are on that, before COVID, 5% of patients who were offered a video consultation took that offer. During COVID, 68% of patients took that offer. So we're moving in the right direction, but we know there are a number of people who still need to see us face to face. We're going to evaluate that for 6 months to establish sustainability, and thank you to all our patients for their patience with us during this period.
Thanks, David.
Back to Jackie.
I don't know if David, Lisa, if you want to come back in, or if you've got anything more to say.
I know that just to observe that was kind of a relatively lengthy kind of update, but I think there was like a huge amount of kind of rich content in that, and I'm happy to then open it up for any observations or questions. But we did feel it was important in this kind of public meeting just to be able to set out for IJB members what our current response has been and continues to be going forward for in the work we've been doing around COVID. So happy to open up for questions from there if that's what you want to do, Jacqueline.
Thank you, David. Before I open up to questions, I just wanted to say it was really good to get a flavour of the services. We don't normally go into that sort of detail, but I think during this crisis it was good to see that detail so that we were aware of the challenges that the officers faced, and, as you say, the people using the services, how it was for them. So it was good to see that, and thanks to everyone for providing that update. I know I asked you to keep it brief, and thank you for doing that, because there was a lot of information there, but I imagine we'll have a lot of questions, so thanks for keeping it as brief as possible. So I think the first person with their hand up was John Matthews. So John, I'll bring you in.
Yes, thank you very much. As a new boy, just hearing what's going on in Renfrewshire, it's great to get such a tour de force. And thank you for collapsing it into a much shorter period than you would probably want to do in doing justice to all of these subjects. But thank you very much. My question is about, I think we're all very aware of the danger of stressing and medicalising mental health. And I wondered if some could say something, maybe it was Christine say something, and maybe Stuart as well, is about social prescribing, because we know that and it's well known that, you know, loneliness, and that's always been the case, whether pandemic or otherwise, that just these things, and we know that they now have worth. I think we're gathering that, and I just wondered if I could say just a sentence or two about that, notwithstanding the fact that we're in a pandemic and it really is getting a laser focus at the present moment.
Thank you, John. I'll pass to Christine first of all.
Okay, thanks, John. Yeah, we absolutely agree with that, and we're very keen that people who wouldn't normally come to our mental health services but do require some support around their mental health and their mental well-being, that we are able to provide that. So we're looking, just in the last couple of weeks, we've been looking at what we can possibly do in developing some of the doing well. So our primary care mental health team, what we can do in that, and we're looking at using some of our Action 15 mental health money for that. We have had very early conversations, and Francis can update on this, with our partners, RAMH, around what can they provide. And we've also, and Stuart can talk about this, we are kind of exploring what we can do in terms of increasing that social prescribing, and can we utilise some of the Action 15 monies for that. So that there are some funds there that's available. It's non-recurring, so it's fixed term developments that we can, but we've absolutely looked at how we will tackle and respond to isolation and loneliness. So people's mental well-being rather than significant mental health issues, but something that's maybe been made worse by COVID and just the general concerns that's came around with that. I'll pass over to Stuart.
Thanks, Christine. Yeah, I think the only other thing I would add is the community link workers that we've got based in every practice. So we've got 29 practices, each with their own attached community link worker who are employed by RAMH at the moment. And that's been a fantastic resource, because that really has been a kind of holistic psychosocial approach to people's problems. They've been linking in with partners in active communities and Linstone Housing Association to support people with welfare, financial issues, housing problems. And I think having that there pre-COVID has been really helpful kind of throughout the COVID crisis, because those staff have been working remotely and by telephone. Obviously, it's not quite the same model as it was prior to then. So I think we've got a good foundation, if you like, to build on. Without a doubt, though, there has been a huge impact of the lockdown and of the financial impact on people's lives we're going to see in the next 6 to 12 months. And I recall working during my psychiatric rotation as a trainee when the financial crisis hit in East London, and obviously we had huge numbers of people massively affected by that. And I think we're under no illusion we're going to see a huge low level and increasing higher levels of need in terms of mental health in the months ahead. A lot of that is managed, as it has been in primary care, and a lot of that is relationships with people's GP and conversations and therapeutic conversations with people's GP, and sometimes that suffices. Other times it'll be signposting to the community link workers. Doing well is on its way back to being up and running again, and additional support for that will be great as well, because I think that's an incredibly valuable service that is, although it's not, you could argue it's medicalizing in a way through psychological therapy approach. It's not a pharmacological approach or a solely pharmacological approach to managing people's kind of mental distress. So yeah, I think I hear what you're saying, and I think we continue to make every effort we can to provide as much kind of wider social holistic support as we can.
Thank you, Stuart. I've got Max wanting to ask a question. Max?
Thank you, Jacqueline. First of all, thank you to everyone who's presented on the services this morning, because actually we don't often hear about every service in these meetings, and we often focus on one change or something coming through that's different. But actually, it's a good reminder of the volume and the breadth of work that's happening in Renfrewshire, and the huge amount of work that's going on. So I really appreciated that this morning. So thank you, everyone. And I guess a lot of that discussion has been around the users and services, as rightly should be. I would like to hear a little bit about actually what's our sense of how staff are coping at the moment, because that's a lot of change, and it's a lot to deal with, and we know as human beings we're generally not that good with lots of changes all at the same time, and it's not only their job that's changing, their personal life has changed inevitably. So there won't be an easy answer to this, but I'm just trying to get a bit of a sense of how resilient do we feel the staff are at the moment, because particularly given what we've just heard in the news overnight in Manchester, this could change in a backward direction very quickly as well. So what are we doing in preparation there, and are we doing enough at the moment?
Thanks, Max. So Christine's got her hand up, and I think David's got his hand up as well. So Christine, do you want to go first, and then David will?
Yeah, Max, we're very, very aware of the impact this has had on our staff, and I think not just in their professional life and their personal life, that they are concerned, they have the same concerns as all of us have about keeping their families safe. So certainly within a lot of our areas, we have developed rest and recovery areas, so particularly for inpatients and for care at home, where staff can take some time out, touch down, get a coffee, a water, you know, and a bit of kind of relaxation, because it's full on, especially in some of the areas. There's also a helpline. So there's a helpline for if people don't want to talk to their managers or their colleagues or their families, that they can talk to. It's often easier to talk to strangers. And some of there's psychologists, some of our psychology team across GG&C are staffing that, so that they can actually provide kind of brief interventions, if you like, quickly to our staff about how to cope. We're very conscious of it, and we're also encouraging staff, rather than banking their annual leave, we're encouraging staff to take some annual leave. We all need you know, some time out, because it has been absolutely full on. So we're doing a number of things, I think, to support our staff, but we're very aware that it is full on.
Thanks, Christine. And I'll pass back to David first, and then we'll get Lisa Marie after David.
Yeah, I think Christine's helpfully just set out some of the kind of area by area issues that we are dealing with. I think at one level, Mags, it's a vitally important question, because at one level we don't know how individuals are coping, because this is a very personal set of emotions and responses. But the important point is that we are doing all that we can to ensure that we understand as best we can how our staff are, and as Christine has really helpfully set out, responding in the best possible way to support them. I also put out each week a kind of a chief officer's message, where we're continually prompting staff to be thinking about their personal health and well-being, about their own mental health, about exercise, and navigate them to all sorts of really helpful kind of interactive website points where they can seek advice and hopefully get some benefit from that. I also want to kind of overlay that with the general point that I think, and it's often been said throughout the COVID period, I think the response that our staff have shown in terms of their ongoing commitment to work, managing very safely their interaction with each other, but also with service users and patients, has simply been outstanding. And I know that's it's almost been said publicly to the point where it's becoming maybe a bit of a tired message. But I think that the fact that we have done all that we've done, both as managers, leaders, and frontline staff, has been simply phenomenal. And I wanted to use this opportunity just to acknowledge that, both to IJB members again, but also publicly, given that this is a public and recorded meeting. And there are some fine examples right the way across our services about the complete dedication that people have had to continue to operate in very high risk areas, but practicing the most appropriate levels of infection control. I also want to pay credit to our contracted services, to GPs, community pharmacists, community optometrists, and dentists as well, and who have at varying degrees remained opened or operational. GPs particularly, and community pharmacists particularly, have continued to be open and have adapted incredibly quickly to deliver services in new and novel ways. And it's not a competition at all, but Renfrewshire GPs have shown to be amongst the highest users of the Attend Anywhere near me software. And Stuart could probably say a bit more about that. But I mean, there have been some fantastic examples, and I just want to kind of publicly pay credit to all of our staff for the response and their continuing resilience. That said, going into the winter, in darker periods, in terms of daylight hours, in terms of more challenging times when we've got winter symptoms that are presenting and the flu vaccine that's coming, we don't underestimate that's going to have a further fatiguing effect on staff.
Thanks, David. Now I've got a small queue forming here. So in order, I'm going to ask Lisa Marie Hughes, then Fiona Milne, then David Wiley. Also, before that, I just wanted to reiterate what David said, that it's clear the power of work that's been done, you know, via these updates, and we were aware of it, but given that more detail, you know, just details like the fire in the toddler unit, I had no idea that had happened. So you've obviously been facing a lot of challenges, and I'd like to publicly thank all of you for all the work that's been done. So I'll pass now to Lisa Marie.
Thank you, Jacqueline. My first question was similar to Mag's about staffing, so I won't ask that because I think we've gone over it. But as a former practitioner, I have to say I'm in absolute awe of the work that staff have done in these times. It's challenging to do our jobs anytime, to be able to do it now is amazing, and you've all adapted so well, and it's brilliant. So that's all I'll say in that. My main question was around the adult with incapacity, particularly contested cases issue, because seeing it ×8, people waiting to have it go through. As I said, I'm a former practitioner and I was on the other side of it. Is there preparatory work you can do before to make it go quicker once we are allowed to get back into courts and deal with things, because it is such a complex and long process anyway? I'm just wondering how we pre-plan so that we shorten it as much as possible.
Yeah, it's a really good question, Lisa Marie, and we're already doing that work to progress it. So as soon as we get the go-ahead with the courts, we're ready to go. So what we're doing is we're prioritising those very complex cases. We're already undertaking with the consultants and the registrars those complex assessments, so that as soon as we get the green light in terms of face-to-face hearings that we need for some of those contested, really complex areas of work, we're ready to go. But unfortunately, part of that delay is around our court processes, and whilst they're starting to open up the courts for criminal cases, in terms of those face-to-face hearings, we're nowhere near the starting block with that. But there's lots of work being done nationally to look at, can we do things slightly differently for those cases? But I take your point, it's absolutely for those people who are waiting, you know, the impact of that on their already complex situation is really challenging.
Okay, thanks for that, Karen.
Thank you, Karen. And next was Fiona Milne. Fiona? I can't hear you, Fiona. I don't know if you're on mute or if you're... Yeah, I think you're on mute.
Can you hear me?
Can hear you now, yeah.
Okay, so can I just feedback from the Carer Centre and also both from my own personal experience, how grateful we are for the continued support that's been offered and put in place very quickly during COVID. It's also been a learning curve about how well digital support works, especially for Renfrewshire's autistic community, who are very often socially isolated. I would like to see this style of support continued.
Thanks for that, Fiona. It's nice to hear something positive. I know that we have had lots of positive feedback, but yeah, it's been difficult for carers, and we appreciate that. So it's nice to get that positive feedback that there has been that support in place. So thank you for that. And moving on now, David Wiley was next. David.
Yeah, thank you. Just to add a couple of things to David Leesy's summary there in terms of staff support in response to Mike's question. Not only have there been the softer elements of support, which I think have been made available, but also certainly around the HP community, there's been a lot of learning and support provided to staff in use of tech and use of Attend Anywhere that has had to be delivered very quickly and very agilely. And so we've been able to get people who otherwise wouldn't be able to contribute to the effort because they were shielding at home or looking after little ones who were vulnerable or elderly parents who were vulnerable, whatever. They've been able to support the effort through virtual triage and a whole stack of other technological elements that required training and support. So there's been support in that area too, Mags. The other thing that I just wanted to mention, which is often forgotten, is the relationship with the HEIs, the universities around our student population and Next Gen, because clearly if we don't provide placements and redefine all of that work in terms of teaching our students to use tech, especially in their final year, and preparing them for the workplace and the workplace they're coming into, there's been a power of work done around that to support our student population, especially final year students who are going to be graduating over the next year, coming into the workplace so that they're better service ready with the tech. So again, there's been support put in there, Mags, through the HEIs and not just in podiatry, but across all the HP services, all of which are facing placement challenges.
Thank you, David. David, at least you've still got your hand up, or was that from before?
Apologies, no, I meant to take it down, sorry.
Okay, no problem. Okay, I don't think we've got any further questions. No.
Jacqueline, just to say that we will share those slides, and if people would value any further information at any point, then either through me or directly to the heads of service, or to Karen, or to Stuart, or anybody else, any member of the IJB, if they've got any questions or want any further information, just contact us and we'll provide that. So it was a tricky balance to try and get the balance of the quantum of information right, but we certainly can share the slides and then provide any further information at any point that people would like.
Thanks for that. Yeah, I think as Mag said, it was a kind of different sort of style of report that we normally get, but I think that we all appreciated it, and it did demonstrate, you know, the day-to-day challenges that everyone's faced. Also, Dorothy's put a comment at the chat. Can we also recognise the trade union representative who supported the staff through the changes? Absolutely. That's an important point to make. Dorothy, do you want to speak?
No, that's fine. I think it is that we all work together. It was a team effort from the staff side and the management to support not just the staff through that, but also for the changes in the services. And like the managers probably were working the hours, all hours that were available to get the changes, because it was happening so quickly. So thanks,
Dorothy. Okay, well, thanks again, everyone, for that. Before we move on to item 5, which is the care homes update, Francis Shannon, Frank, has managed to join us. So, Frank, we've already passed the IJB membership update, so you're officially an IJB member. But as I said to you previously, if you want to say a few words of introduction to everyone, hopefully you're still with us, Frank. Oh, I don't know if you are. If you are, you're muted.
Okay, how's that?
Oh, yeah, we can hear you now.
Okay, but it's okay. I have been in the meeting for quite a while.
Yeah.
Apologies for the delay. I think largely down to Microsoft, I think. Anyway, briefly about myself. I have originally a law background, but became a journalist. Latterly specialising in business and finance, on which I still write. I've also spent some years in higher education, teaching at universities on both media and media law in Scotland and England. Now back full-time within Scotland. So I have to say I've been very impressed with everything I've heard in this meeting and the tremendous amount of work that's being done. I hope I can make a contribution in the future, and I suppose I should just wind up by saying, trust me, I'm a journalist.
Thank you for that, Frank. Well, listen, don't get me started on journalists these days. It's a public meeting, I should probably not say that, but I've done it now, too late.
It's okay. There are good and bad journalists, I will admit.
Also, I just wanted to say that to both you and John, ordinarily, if we were in a room, we would have done a round of introductions, but we couldn't work out a way to do that and how we would know what order. But hopefully Elaine's roll call at the beginning gave you a flavour of who's around, and you'll get to know each other. And maybe one day in the midst of time, we'll all be able to be in a room together, which I'm looking forward to. Okay, so we'll move back to the agenda. So we're moving on to care homes update. Before I pass to Shona, I just want to say thank you for this paper. I think it's very thorough, informative and transparent, and given the media scrutiny, I think that's really, really important. So I'll pass to Shona now.
Thank you, Chair. The paper provides an update on care homes in Renfrewshire during the period of the pandemic to date. The key messages from the report are that it's written from a social care perspective and not a medical perspective. It does not address areas such as DNA, CPR or hospital admission processes. It's also worth the IJB reminding themselves that this is a novel virus, and we have continued to develop our understanding during the period of the pandemic. The report draws on local and national data, It focuses on care homes within Renfrewshire's boundary area and the flow of discharge from hospital during the period the 1st of March to the 30th of May 2020. The report refers to the volume of guidance and erratic PPE supply, particularly at the beginning, and the footfall from agency staffing across the sector, which may have contributed to outcomes for residents. It notes a lack of linear connection between care home standards, outbreaks and subsequent rates of death. What we can see is that timing mattered. It's not consistent, but homes which closed early to admissions have tended to fare better. Homes with early phase outbreaks had high and persistent infection levels, and again that's probably consistent with our understanding of the virus and the way the virus transferred. Care home placements were made throughout the period, but the service took a measured, risk-based approach in line with national guidance. There is clearly a reduction of 28% in our delays in discharge, and that is short of the 50% target that was set nationally. We did not block book beds in Renfrewshire, but worked closely with the care home establishments. In terms of testing, discharges in March and for very much of April were not tested pre-placement. In line with the normal process and the normal pattern in Renfrewshire, the majority of admissions to care homes were directly from hospital. It's worth noting that 67 people in total were discharged and admitted into care homes, from 4 from the community, so a lot less from the community, and 17 of that group from step-down beds in Hunter Hill and Renfrew. It's also worth noting that a further 31 people were placed by other health and social care partnerships in the Renfrewshire area. From the 67 people that Renfrewshire placed in care homes, 8 people subsequently sadly died, 3 with COVID as a contributing factor on their death certificates. It should be noted that no homes at the point of placement had outbreaks or suspicions of infection, and people were fit for discharge. The recommendations are at section 2 of the report, and I'm happy to answer any questions.
Bear with me. Thank you, Shona. I've been faithfully muting and unmuting my microphone, but sometimes there's a wee bit of a delay. Yeah, I'm going to read out the recommendations first. I don't normally do that, but given that it's kind of guiding the questions, I'll read them out. So it's recommended that the IJB provide scrutiny to the content of the report, instruct any further areas for inquiry or exploration at this point in time, and note that the work will continue to be undertaken to confirm the data available across all systems, and note the National Social Care Inquiry. So given that the first 2 points kind of infer any questions, I thought I would read that out first. So do we have any questions on this item? No, I was expecting a barrage of questions, but I think given that it is such a thorough and informative report, yeah, it makes sense that maybe no one has anything to ask. And as Shona said at the beginning, there has been a lot of scrutiny in this area, and I think what this report reflects is the amount of support that's been given to private care homes. I think that there's been an idea maybe within the public that private care homes are on their own, but this report clearly shows as an HSCP and an IGB what support is provided to them. So Lisa Marie, I see you've got your hand up now if you want to come in, and Shona after Lisa Marie. You're still muted, Lisa Marie.
Sorry, my tablet's been really slow in doing actions today. Firstly, I would associate myself with everything you just said. I think a lot of the reporting is negative, and there is scrutiny there, and that's important. But the picture can look awful when our staff are working very, very hard and people are still receiving a very high level of care, and I think it's important to note that. I did have a couple of questions, but they were around numbers and ratios, and just to note that I've asked them and Fiona replied to me almost within the hour with very, very detailed responses, so I'm quite happy.
Thanks, Lisa Marie. And Shona, you wanted to come back?
Hello, I just wanted to record really to thank the independent sector care homes and their staff group, as well as our internally operated care homes and their staff groups. I think the independent sector, particularly over the last week, has taken a considerable amount of flack directed at them through both the politics of the situation and through the media. But the staff group have worked tirelessly to support their residents in Renfrewshire and have worked very, very well with both all of the clinical staff and the social care staff across the area in order to support the resident group that we have. Thank you.
Thanks, Shona. I think that's really important point to make. I think it's been quite demoralising for the staff in many aspects. So David and Frank have both got their hands up. So David, I'll bring you in first, and then Frank.
Yeah, it's just maybe just to add to the point that Shona was making, I think, because I think, again, just getting under the skin of the issues that have been raised in the media particularly, I think one I wanted just to kind of note the work that has been done by colleagues across the HSCP, because it's been really challenging, both in terms of the intensity of work and the detail of the work, because we are in daily contact with every single care home, working our way through a daily checklist with them of a whole range of questions, seeking information that allows us then to have our daily huddle, that allows us to keep on top and track each day a micro set of issues across this field. And that's required a huge amount of skill, both by colleagues in our organisation, Shona and Sean Doherty, our Chief Social Work Officer, John Traynor, and others. But also it's taken a real skill set by staff working in care homes, because it has brought additional new dimension to our relationship with them. And sometimes that can probably feel like scrutiny and challenge, and sometimes it can feel like we're asking just too many questions. But I think, as Fiona said, right the way across, I think it's to pay credit to staff right the way across who've embraced this hugely wicked and complex challenge and kind of entered into the process of monitoring, of tracking, of scrutiny, of constructive challenge, and reporting on a regular basis with a real level of professionalism. So it's just to acknowledge that, but also to acknowledge that the depth of detail that we have been going into on a daily basis in this field.
Okay, thanks very much, David. Frank?
Yeah, I hate to say this, but I mean, news is frequently bad news, because news is what is out of the ordinary. And in a sense, it's a good thing that, if news is bad news, it tends to mean that most things are going right. But it's very demoralizing for staff, I appreciate that. And especially now when, if you like, what is out of the ordinary, especially, is the amount of work that's being done throughout the health sector, including the care homes. And one of our roles should be to make sure that we get that message out as often as we can, and to put it in a way that the media will pick up. There've been a couple of programs, the Disclosure Scotland program and the Panorama program, but they are focusing on generally out of the ordinary experiences, and we need to make sure that we're available to balance the picture as much as we can.
Thanks for that, Frank. Yeah, that's an important point. I think as well, given that there's going to be a national social care inquiry, that's crucial, because we don't want it to be too defensive. And while in Renfrewshire we were following national guidelines, we do have to learn if we can do things differently, especially if we do have a second wave. So absolutely, scrutiny and accountability is clearly necessary. John, you want to make a point?
Yes, I just wanted to make a point alongside Frank's, and I'm sure you'll agree with this. We're not here to complain about the inquiry and investigative skill of journalists and the media, but it would be good if, when they approach, whether it's Shona, the press office, or in the case of the board, our publicity people, when they're proposing to make some statement or or produce some programme or article, that when they're given facts that obviously fulfil the requirement that they are asking about, it would be good if they took that on board. We have the old mantra, I know, and it's hackneyed, but it's nonetheless, it's got some truth in it, and that is that often journalists and media people don't want to spoil the story with the facts, but it would be good from time to time when the facts are laid out honestly and transparently before them, that they took that on board and then didn't cause a lot of unintended consequences for families and individuals and the organisations itself. I just make that statement.
I'll use the politician's phrase, hear, hear. Thank you. Now, Stuart's got his hand up. Stuart.
Yeah, I suppose it was just really to add to what David and Siona have said. I think there is a far deeper understanding now, and I think we started to hear live from care home staff what was happening in the care homes as part of those multi-professional meetings that we instituted fairly early on into the pandemic. And I think that certainly for me is an area of learning, in the sense that we are in a far better place now in terms of our relationships, communication, links between community pharmacy, between general practice, between palliative care and hospices, between social care colleagues, and between the care homes. That that infrastructure that we have now, and that support that we have now, it definitely stands us in good stead. And the feedback I hear from colleagues who have had what can only be described as an incredibly difficult time, working in situations that none of us would ever have dreamt we would have been facing in our professional careers, that I think that the response I hear back from is that they do feel now that they are getting the support, and that it is welcome having that multi-professional sort of fortnightly meeting that we continue to have. And I think that alongside the daily huddles and the assurance meetings, the other thing to mention really is that the virus is not something that we understood the clinical course of at the start of this, and certainly, sadly, one of the reasons that we saw so many people dying in care homes once they were infected with the virus was the rapidity with which people became very unwell and died. We were seeing people dying within sort of 24 hours of it being recognised that they were acutely unwell, which is not typical for other respiratory illnesses for people to deteriorate that quickly. So I think it is just understanding that, from a medical and nursing perspective, this was what we know now is exponentially greater than what we knew then. But I do think we're in a far stronger position in terms of support, communication, and processes in place board-wide, nationally and locally, than we could have expected to be, or reasonably have been, in February, March.
Thanks for that, Stuart. That's good to hear that. That's positive. Now, Frank and John, you've still got your hand up, but I think it might be from before. Frank, come in.
No, I just wanted to come back on something you mentioned, and John as well, in terms of dealing with the media. It is very easy to become defensive because we tend to be in the back foot and tend to have more responsibilities in terms of protecting people's personal information, and also protecting the public view, if you like. But it often needs quite a bit of courage to put yourself forward as to speak to this, and often the temptation is just to issue a statement. And so the effect is, especially on broadcast media, you get a lot of people speaking very freely, and then you get a statement from, an invisible person, which is then cut right back. So again, I think this is something we could maybe work on over the next few months, is getting on the front foot and really putting the good news forward. Because it is news and it is out of the ordinary.
Okay, thanks, Frank. Yeah, I think the paper's been pretty transparent, and I think, you know, I've worked with David and Shona on requests that we've had, and we've been as transparent as we can be. So thanks for that. Okay, so given I've read out the recommendations, I take it we're all happy just to move forward and note the recommendations. Yep. Okay, that's great. So that's fine. We'll move on to our next item, item 6, which is response and recovery planning approach update. And I think I'm handing over to Frances.
Yes, yeah, thank you. I'm just going to wait for James to upload the slides. Hopefully I'll see them this time, or I'll be working blindly. Oh yeah, thanks James. Okay, if you just go into the first slide, that'd be great. Thanks. So this update really builds on upon the more detailed report that we brought to the June IJB, which summarised our COVID response to date and also set out our emerging approach to recovery and renewal. So this presentation is really just to update members on the progress since then, and it picks up on a lot of the themes that have already been discussed in today's meeting. So this first slide just highlights the current position that we're in, which is quite challenging, where we're still in the midst of recovery, where we're still responding, still in the midst of our response, where we're responding to COVID, whilst recovering services in line with national guidance. And as you'll all be aware, that guidance can change quite rapidly. And along with that, thirdly, we're starting to plan for the future and our recovery response and how we'll renew and transform. And this is in recognition that we don't actually want to go back to the pre-COVID state for all our services, that we want to build on the learnings from this experience, both the good and the lessons learned from this experience. And these activities have been undertaken in a period of great uncertainty and considerable challenge, and some of those we've already talked about, and they're provided, some examples are provided at the bottom of the slide, where we're having to balance our organisational capacity to deliver all the response, the recovery, and our planning, when we're trying to still give staff some time off that have been working tirelessly through the initial response. We're still continuing to deliver COVID services. We've got staff redeployed to test and protect. We're still heavily involved in the care homes. The financial uncertainty, which Sarah can pick up on later, and then we're starting to have to turn our minds to winter planning, and there's new pressures, which, for example, Stuart touched on earlier, where there's significant expectations around the flu vaccination being placed on the HSCP. And as part of this planning, the potential for local outbreaks or a second wave need to be at the forefront of our minds. And I think it's important to state that we can't assume that the sequence of response, recovery, and then renewal transformation will be a linear process, and that we've got to be prepared and have the capacity to be able to respond to that really real and continued threat of COVID. James, if you go to the next slide. So for those very reasons, our approach to recovery is still very much evolving, and it feels it doesn't feel a mature enough stage yet to formalise our governance approach to our recovery programme, as we need to ensure that our thinking is informed by the wider system, so that we explore the lessons from COVID with our partners, the partner organisations, the Council and the NHS, and our wider partners in the strategic planning group. And also that we ensure that any of the work that we do aligns with the wider transformation programmes and recovery programmes in the Council and in the Health Board. And we also want to, importantly, listen to our staff, the staff that have been at the forefront of this response, working in the front line, and make sure that our way forward is informed by their reflections too. So really this slide is just to highlight that our focus just now is on managing those linkages, and we've highlighted in this slide some of those key linkages, not all of them, but just to give you an idea of what will inform what our governance approach and how we work will look like going forward. James, the next slide. And this next slide just highlights some of the work that we're doing in that space, some of how the reflections of COVID are informing our planning approach. So we've been involved recently in the Scottish Government's delayed discharge lessons learned. We've carried out some reflective surveys with our leadership network, which is the sort of core group of 120 sort of managers and team leaders in our organisation. We've surveyed staff around how we've communicated with them and had some really positive feedback, particularly in how they feel the Chief Officer has updated and engaged with them through this process. David's been holding a range of meetings with other HSCP Chief Officers to explore opportunities for how we can do things in partnership and more collaboratively going forward. So there's a range of examples there, and hopefully in the coming weeks we will have a similar session with yourselves as our IJB to collectively get your reflections from this period too. James, next slide. So as part of our planning discussions, a number of cross-cutting enablers and key themes have come up as critical that will need to underpin any future recovery programme, and many of these have already been discussed today. So workforce and organisational development, digital property, and these there's considerations both in the short and the longer term around these that we need to consider. For example, in the more immediate, we need to ensure that our properties are fit for purpose and reflect the guidance as it emerges. But we also need to think longer term around our workforce, the skills that we need, how we need to develop our staff and training. And money is obviously a big consideration as well, that we need to ensure that all our future planning aligns with our financial plan, and we work closely with Sarah on that. So as a senior management team at the moment, we're currently reviewing our capacity and capability to drive these areas forward, and how we'll work with our partner organisations to do this, and we'll keep the IJB informed of our progress as we go with these areas. James, the next slide. So this slide should be very familiar to you all as IJB members, and it's really just a reminder of the two key strands of our planning approach. The first strand being the community health and wellbeing work that we're progressing and using the SPG, our strategic planning group, as the key vehicle for that, and also linking in with our community planning partners to push for a Renfrewshire-wide response to public and population health. So it's very much looking at a collective response and how we get a shared responsibility and ownership for this with our communities, and we encourage a sort of person-led approach around the public health and wellbeing in line with turning the tide. The second strand, which you've heard more about today at the beginning of the meeting from our operational heads of service, is about our internal change programme. And just picking up on strand one, we've been doing a lot of work with our SPG, and we recently had a meeting which Jacqueline was part of. James, if you go on to the next slide. We've been working with the SPG for the last year before COVID as part of our transformation programme to identify common priorities, and the priorities that are on this slide were priorities that we agreed back in February. And more recently, in just the last few weeks, we had a session bringing the partners together to reflect on our COVID response in Renfrewshire, the learnings from that, but also to go back and test these priorities. And at this meeting, I think it was fairly unanimous that everybody felt that these priorities were still valid, and in some ways, some of them have actually been exacerbated by the pandemic. In addition to that, though, the group did identify a number of priorities or priority groups within these that we need to consider, such as children, carers, people that will become unemployed as part of this process, and the bereaved. So some that we know have been disproportionately affected by COVID, but others that we anticipate will be affected by the longer impact of the pandemic. So we've got our next meeting of the SPG on the 12th of August, and the focus of that meeting is to start to turn an eye to look at what action we collectively want to take. And there's a real desire to look at a Renfrewshire-wide response where each of the partners looks at their strengths and plays to their strengths, recognising that the HSCP cannot turn the tide alone, and that this needs to be a much wider response, both in Renfrewshire and working with our public health colleagues at the board. So at the next meeting, we're looking to develop what action we want to take, and also the areas that we wish to influence collectively around the sort of socio-economic determinants of health, such as transport, housing and other areas. James, if you could go on to the next slide. And then just finally, I just wanted to wrap up. It's just been really a quick whistle-stop tour of some of the key areas that we've been working on since the last meeting, and I just wanted to highlight the areas that we're looking to take forward in the next reporting period. So we're planning to, as I mentioned, undertake a lessons learned with yourselves as our IJB, and we hope to start developing our recovery and governance model so that we can bring that to the meeting in October. We also will have our next meeting with the SPG, and we'll keep the IJB informed of the action plan as it emerges and the proposals of how we plan to take forward the work under Strand 1. And we want to start creating more structure around the operational recovery work that the heads of service talked about at the start of the programme, so that you can start seeing that in a much more staged, formal programme way. And also we're doing some work around the cross-cutting enablers. So how are we going to increase our digital capacity? How are we going to ensure that we have the right support for our workforce, both in the short and the long term? How will we look at our accommodation? And then finally, we want to invest more time working with our leadership network, that group of core senior managers, and work more with them, which is probably the area that we've had the least ability to do, given so many of those managers have been diverted to actually working on the front line and still dealing with the response and ensuring they've got the capacity to keep the lights on. So over the coming weeks and months, we're looking to have much closer involvement with these managers and their teams. So that's it, and happy to take any questions. Thanks.
Thanks very much, Frances. Yeah, I think John's got a question he wants to ask.
Yes, thank you for that, Frances. I had an hour with Frances earlier in the week. She offered that and I took it up after our introductory meeting with you, Jacqueline and David and others. I wanted to draw attention to the opening paragraph under the segmenting recovery and renewal activity, and that is that we are working almost under emergency powers at the moment, which are held and directed in Edinburgh, and I want to say this very carefully because I know I'm in a public meeting, but we're doing things, some things to say it positively, some things that would have taken us 2 years, we're doing in a fortnight, and that's great, and we want to capitalise on that. But while we're doing that, this opening paragraph says that that's understandable, but it raises the risk of us conflating these emergency ways of working with the transformational plans that we had pre the pandemic and the lockdown. And we really need those levers that are being held at the moment centrally to be released, so that Francis and the Renfrewshire IJB can get back to doing the things that they want to do transformationally and in terms of what they see as the recovery. I just highlight that. The other two things quickly that I'd like to mention, one was the second last slide, which is the Strand 1 activity of health and well-being discussions with the strategic planning group. These are certainly the priorities. But I'd want to say that, and I declare an interest here, I chair and have chaired for the last 4 years the Standing Committee on Public Health and Wellbeing for the board. And we really do need to, we all believe it, we all say it, but it's the most hardest thing in the world when finance is so tight, and that is that unless we build the fire break years down the line to get that benefit in terms of public health, and almost babes in arms are saying now that that everything to do with the pandemic and to do with the virus has underlying health conditions, and that's to do with public health and population health. And we really need to put our money where our mouth is and take a deep breath and do things that will reap the harvest of better health, better choices in the future. And just in passing, in terms of workforce and organisational development, there are going to be tens of thousands of people unemployed, sadly, very sadly. And we know the consequences of that for health and well-being. But they're there to be retrained. Our own staff can be upskilled to make room for people coming in at the bottom end. Now, again, all of that takes courage. It takes skill, it takes inventiveness, it takes creativity, and it takes finance. And Sarah will have something to say about that in terms of her search for clarity in terms of the money that she has to be able to spend. But it's an opportunity, it's an open door. And we keep saying we want to take advantage of these things. We actually have to do it. Sorry for that big long speech.
No, thank you, John. It was a good speech. Very important points that you made. I don't know. I'll pass back to Francis because I think your first point, you might want to make a comment on how getting back to the new normal will, align with our original transformation programme. Francis.
Okay, thank you. Yeah, I think it's important to note that actually the slide that we put up with the two strands are actually the same two strands that we initially had in our transformation programme. Those 4 guiding principles have not changed, and I think it's the strategic priorities of this HSCP remain the same. What has changed and needs to change is our approach and the pace that we can do things in the delivery. But in terms of guiding principles and what we're trying to achieve, I think it's interesting to note that both those and the priorities of the SPG have actually remained consistent, which shows, I think, that we were in the right direction prior to COVID, that this hasn't actually changed the work we're doing. It's just that we're now operating in an even more challenging environment. That said, there's a lot of opportunities that have come out of COVID. It has pushed our digital, I suppose, the desire to work digitally, it's pushed that a year
Okay, thanks very much, Frances. I'm going to move swiftly on now, because I think I know that for John and Frank, some of this information is fairly new, but we've covered it, you know, in quite a lot of depth. And given the time scales, I'm going to move on. Okay, so Sarah, I'm hoping that your IT problems have resolved, because we're now moving on to item 7, which is financial implications of COVID-19 on delegated IJB budget. So hopefully everything's okay, Sarah.
Thank you, Jacqueline. I'm not sure, it keeps coming and going, and I noticed that my hand keeps getting raised, not voluntarily, so I have no idea what is going on with my IT this morning, so apologies. If I'm frozen when I'm doing this, I hope that David would be able to take over mid-spiel, so I'll do my best, but apologies in advance if I lose any connections again. So in front of you, you've got quite a high-level summary of the financial implications of COVID-19 on our delegated budget. And I suppose what I need to emphasise to members is that at the moment, it's still not clear what the ultimate impact on our finances will be, and everything at the moment is a best guess. And we're working very, very closely with other HSCPs within the board area, and also the board and the Scottish Government, to try and tie these costs down as best we can, and in addition with Renfrewshire Council too. So there are, in section 2, there are a number of recommendations that I'll come back to at the end of highlighting the main issues that I want you to note today. But there's some very important, quite difficult decisions for the IJB to make, but I think we are in a really high risk financial position at the moment, that I want to make that very clear to everybody. So one of the first things to note, and it's in section 3 of the report, is that actually at the moment, due to the delay of COVID-19, we don't actually have formal notification of our 2021 delegated health budget, and that's because the board has had to pause some of their board meetings where this would normally be approved. So we're hoping that at some point in the very near future that we will get formal notification of our 2021 budget, and it will be in line with what we're anticipating. So that's still an outstanding issue for ourselves. In response to the pandemic, and Frances and the other heads of service have discussed in full what we did, how we actually managed that. In terms of finance, what we did right at the start, and this was in response to the Scottish Government, was we started inputting to a financial template called the Mobilisation Plan template, which was updated regularly to the Scottish Government. We update that on a weekly basis, and it gets sent to the Government now on a monthly basis. And in this, we record all our additional costs that we are incurring purely in relation to COVID-19, and there's a really rigorous audit trail of what those costs are and what I've agreed that could be coded to COVID, because I'm very conscious that at the end of this there will be some kind of review and our external audit will want to see how we manage this. So there's a lot of financial governance sitting behind this. But also in saying that, there are huge estimates going forward as to what those costs may be, and the majority of those are in relation to provider payments that we are expected to pay on behalf of the Scottish Government. So section 5 of the report refers again to our medium-term financial plan, which the IJB agreed in November 2019 prior to COVID. So all of the assumptions that we built in there did not include the impact of COVID-19. So it is very important that we note that, and that we actually will need to revisit some of these plans that we had agreed initially, although, as Francis said just there, that actually the same strands still apply, and we would still be taking forward those same transformational plans when we actually have ceased pausing that activity. But we do need to have a very flexible approach to our financial planning to enable us to move forward. Section 6, which is probably the key area within this report, explains the work that we've done that I've highlighted to do with the local mobilisation plan, but also there's some quite scary figures in section 6.6, and this is the estimated cost for us at the 20th of July. So you'll see at the moment we're estimating the total cost could be anything up to 25 million. The biggest part of that is the provider sustainability costs, and at the moment we don't know what they are going to be. Along with all of the IJBs across Scotland, we have an agreed assumption of what that could be, and we would hope that that will reduce in time as we get information back from our providers. So everybody is dealing with this in a slightly different way across Scotland. In Renfrewshire, we wrote out to all of our providers and asked them to complete various templates and get us the information back along with supporting documentation to allow us to verify claims and to make payments. So we're still a long way off getting that information back to them because they're obviously having difficulties going through their financial monitoring systems and getting that to us given the other pressures on them, but we are closely working with them. We have made payments to all of the care homes in the area in terms of under occupancy. However, we have now spent all of the money that we've received from the Scottish Government, so no more payments will be made until we receive more money, because it would then put the IJB in out of financial balance. But we continue to work with our providers. We have ongoing dialogue with them on a regular basis, and they are very much clear about our position and that we're doing our best to accommodate them. So these figures could go up and they could come down. I absolutely do not know what that position will be. In addition to that, we don't know how long the provider sustainability payments are to go on for. The original assumption was to be up until today. We haven't had any update from the Scottish Government as at today, whether it goes into August or not. The payments for enhanced sick pay do go on into September, so we will continue to honour those. But we're waiting for confirmation. There's a meeting with COSLA today and the Scottish Government, so I'm hoping that we will hear very soon whether we have to extend this or not, albeit we don't have the funding to make these payments. So Section 6 discusses that absolutely in full. It also asks and makes a proposal to the IJB that the Chief Officer writes to the Cabinet Secretary seeking a firm commitment, because as yet we do not have any firm commitment that we will receive all of this funding. And within the report, I've attached appendices of correspondence that we've received initially from the Cabinet Secretary. So we're seeking firm... Oh, that's not me. I haven't got any aeroplanes in the background. So we are seeking firm commitment from the Cabinet Secretary that they will honour the payments that we need to make, both to enable us to ensure the financial sustainability of these providers, but also of the IJB, and that's very key. And in addition to that, there's a recommendation in 6.13, which is in section 2 of the report, that no further sustainability payments are made until we receive this confirmation. So I won't go in any more detail of the report, because I'm assuming that you will have read this in detail, because it's quite a weighty tome for you all to have waded through prior to today. But I'm happy to take any questions, but also just to remind us that there are recommendations in section 2 to note for the report, but there are 3 which needs agreement. And the first one being that the Chief Officer develops a range of proposals for the IJB's consideration to support our ability to deliver a balanced budget in 2021, that we agree the recommendation that the Chief Officer writes to the Cabinet Secretary, and that no sustainability payments are made until we receive further confirmation from the Scottish Government in this respect. So.
Thanks, Sarah, and thank you again for this paper, which again was really thorough and informative, and more robust maybe than normal finance papers in terms of the stance that we're looking at. But yeah, and I know I often have to be reminded that we're noting and agreeing, but if ever there was a time that I'm going to make sure that we do, I would draw everyone's attention to the section 2 recommendations, because if there's anything that any members aren't happy with, the voting members, we need to know now. So any questions on this paper at the moment? Dorothy, and then John. Dorothy first.
Thanks, Jackie. It was just to say that firstly, a very detailed paper, and it gave us a lot of information. So I understand that we're under a lot of financial pressures at the moment, because of COVID and all that. But I know that we stepped down services. So are we going to use that money as offset? Because we must have made, you know, there must have been some savings in that respect, albeit we might have redirected it. So it'd be good to know that, of what we've done with that. And also the letter to the Cabinet Secretary, are we aware that, sorry, somebody came in and spoke to me just at the tail end of your conversation, or your report. So are we aware of the other HSCPs are following the similar line, so that we're doing that as a collective? Because I know that that's been a great piece of work going throughout this COVID, how the chief officers have worked together collaboratively, and it's been really supportive and a good way of working. So it'd be good to know that also. Thank you.
Thanks, Dorothy. Sarah, I'll bring you in, and then we'll get John afterwards.
Okay, in terms of the offsetting, we don't at the moment have a clarity on what that could be, Dorothy, and one of the reasons for that is you would think potentially we have had fewer admissions into care homes. However, the contra to that has been that our care at home services have the number of clients that they're having to deal with, and the cost associated with that has increased significantly. So we're not yet clear what that actually means for us in terms of finance, because that is changing almost on a daily basis as people start to be admitted into care homes more than they have been over the past few months. So that is a balancing act that we're not yet clear about. We do also have issues in relation to unachieved savings, which are highlighted in the report. So any underspends will possibly need to fund the shortfalls in delivery of savings, and also in prescribing. And within prescribing, part of our budget was based on the fact that the pharmacy teams would be able to deliver efficiency initiatives, which they usually start in April. Because in totality, those teams have been working purely on COVID, they've not actually started any of that work. So it's like any underspends that we have will need to offset prescribing. It's still very early on in the financial year to know which way the position will go. We do have vacancies which we're trying to fill. So you'll see in my first finance report, which will come next month, there will be some clarity, more clarity on the figures, but it's very, very early on for us to know exactly what this means for us. So at the moment, it's very much up in the air, Dorothy, in respect of offsets. The other side, the other question that you'd asked was, what are other HSCPs doing? I'm on the CFO exec network, and I've raised what Renfrewshire is going to do, and I've also shared the narrative with other CFOs who are taking this back to discuss with their chief officers and their chairs. We are not all on the same page. Others are not showing this as a risk at all. So it really depends. I would hope that that there will be others in the same position as us, but we are all reporting things in a different way at the moment. My view is very similar to that of the board. They're showing the COVID expenditure as a huge financial risk to the board, which is what I will do as well. But that's up to the individual CFOs on how they report that. But I've certainly raised it with all of them.
Thanks for that, Sarah. Yeah, I think it was a question I had also asked Dorothy at the pre-agenda. I think so, yeah, so it remains to be seen yet, Sarah, whether others will follow in the same path. Dorothy, do you want to come back, or are you happy with that answer? No. Okay, I'll bring John in next then, John.
Thanks, Jacqueline. I too had the advantage. Sarah offered me the opportunity to speak, and we had an hour or so talking about the accounts. And I like the way they have been so plainly stated in the sense of what the issues are for us, without any glossing, and that's really important. My question is, did you, Sarah, write directly to the Cabinet Secretary for Health? I see Jean's response with her typical handwritten postscript at the bottom to soften the couple of paragraphs of what she's done above. But my question was, did you write to them, to the Cabinet Secretary, and whether you had any kind of reply? It's disappointing to think that all the chief finance officers, as Dorothy has drawn attention to, are not acting in concert. But it's absolutely essential, and you and I discussed this, and you're doing it and saying it in the paper. You're keeping an audit trail, because not just politicians, everybody has, but particularly politicians have short memories, and they will come back and say, oh, but that wasn't COVID. I don't know why you're putting that in the COVID account, unless you have clear dockets for that in terms of the way you account. Then it'll be very difficult to prove that you haven't been spending money on normal business, as it were, which was not at all normal at the time, and that you were being pressed to spend because of the emergency of COVID.
Okay, in answer to your question, John, no, we haven't written. A draft letter has been prepared, because obviously I'm waiting for the IJB's decision today. They need to agree that recommendation before we send a letter to the Cabinet Secretary. The letter that's attached in Appendix 1 was actually sent to everybody, to all chief officers. So we don't have an individualised response from the Cabinet Secretary. So providing the IGB is happy to approve the recommendations, we will be firing that letter off immediately after the IJB.
Thanks, Sarah. Okay, so I'm not going to read out all the recommendations, they're there, but if I could just ask that we can note the recommendations that are laid out and agree the recommendations that are laid out. And if anyone has any objections, please raise your hand. Okay, that's fine. So we've noted and agreed all the recommendations in that report, and Sarah will take that forward for us. Thanks very much. Okay, so moving on to the last agenda item, or second last agenda item, is local code and sources of assurance for governance arrangements, and I'll pass to Jean for this item.
Thank you, Jacqueline. As previously agreed by the IJB, the local code and sources of assurance for governance arrangements is to be reviewed in what is now known as the Audit, Risk and Scrutiny Committee. This code provides a mechanism which allows the IJB to assess the governance arrangements that are in place. It allows the IJB to demonstrate that its governance structures comply with the Delivering Good Governance framework, which is for local authorities, but a lot of it is mirrored within the IJBs. Appendix 1 provides examples of the systems, processes and policies that are in place to demonstrate compliance with the framework. The code was reviewed by the Audit Risk and Scrutiny Committee on the 19th of June, where the recommendation was for this report to be presented to the IJB. The recommendation is there for the IJB to approve the local code of sources of assurance for governance arrangements. Thank you.
Thanks, Jane. Sorry, my microphone was taken for a... Sorry, I've muted and unmuted, and so Lisa Marie, you've got a question?
No, just a comment. I'm going to be that person because I think Mags would want to make a comment now, and she's not here. So as the next person to her on the audit committee, I'm just going to say that there's been a significant amount of work been put into this, which I think is evident from the detail in the codes of assurance, and I think it shows the level of strategic and operational governance, and it's multi-partner as well, which I think is really important. So just to thank Jean and the people who've put it together, and to assure you that it's been heavily scrutinised by the audit committee.
Thanks for that, Lisa Marie. And it was an update from a paper that we'd seen before, so I don't imagine there's too many more questions in that. So no, it looks like nobody else has got any questions. So are we looking at section 2? Can we approve the local code? No dissent. Hands up if there's any dissent, and there's none. Although your hand's still up, Lisa Marie, but that's from before, so that's fine. So that's fine. We can approve that item. Okay, everyone. Well, thank you. So the last item on the agenda is date of next meeting, which is going to be the 20th of August. Again, remotely via Teams. Eventually, we'll get to meet up in person, as I said before. And back to the scones. Frank and John don't know that, but about the Abercorn Centre, we get tea and scones. So one day we'll go back to that. But thank you, everyone, and we'll see you next time on the 28th of August. Bye for now.
Thanks, John.
Thank you.
Bye.
Thank you. Bye.
Yeah. Thank you.